Okay, well, welcome to Chapter 4. We're going to be discussing prenatal development and birth in this chapter. So, first we begin with conception. I always like to tell my students in class, if you're really interested in what leads up to conception, you're welcome to take my human sexuality class. I'll just say that this sperm and this egg met. This sperm in this picture has already gotten through the coating of the egg, and that has caused an electrical impulse to occur on the surface of the egg that prevents any other sperm from being able to permeate the shell of the egg. That helps to ensure that only the DNA coming from this one sperm will be able to line up with the DNA coming from, actually with the genes from this one sperm to match up with the genes from this egg. So we'll end up with the 23 pairs of chromosomes that we expect in a healthy offspring. If two sperm were to make it through the shell at the same exact time, it would cause destruction of the egg. So one sperm meets up and penetrates one egg, and that's what we call conception. Now from that point, this conception, you can see up there in the fallopian tube, conception is highlighted in bold. So the sperm has met the egg and conception has occurred. Now, thanks to the action of the cilia that line the fallopian tube, that zygote, that single cell, is going to start moving its way down the fallopian tube toward the uterus. So it's a single cell in that first picture after conception, then it starts to divide. And so this is what we call the germinal period, where it's going from a single conception to 2 cells, then 4 cells, and so on until it reaches the uterus and implants in the uterus. So we can see here in this diagram that this zygote is ultimately going to become a blastocyst that implants in the uterine lining. Okay. At this point, we enter the embryonic period. I've linked a video here for you that you can watch. I've linked it in our online classroom, so that illustrates what exactly is going on developmentally with the embryo. So I'll let you guys watch that separately. I thought I would stick in here a picture of embryos from different species. So if you look along the left hand, starting at the left-hand side, we see fish, then salamander, tortoise, chick, rabbit, and then finally on the right-hand side we see human. And if you go up to the level A, unless you're an embryologist or really know your species, you would be hard-pressed if all I showed you was one of those pictures and said, what creature is this? For you probably to be able to figure out what it is. They look very similar. When we get to row B, we're starting to see some serious differentiation of the fish and the salamander versus what are going to be 4-legged animals, right? Tortoise. Now you might be saying to yourself, hey, chicks only have 2 legs, but the wings count as a leg, right? Those are 4 arms that have developed feathers. And then absolutely, I mean, look at rabbit versus human, even on row B. Rabbit versus human is really hard to tell the difference. There used to be a TV show on like the Science Channel that was called In the Womb. If you want to try and find it, it's called In the Womb. And what I always like to do was join the show in progress after they've already told us what it's going to be, and I've missed that part. And it was sort of like a Where's Waldo kind of game for me, where I'd be like, okay, what animal could this be? Sometimes it was a golden retriever, sometimes it was an elephant. You never knew what you were following through gestational development. And some of them you really couldn't tell till very late. I mean, look at on row C, rabbit versus human. I mean, they look different now, but not probably as different as you would expect, right? During the embryonic stage, it's really, really hard to tell the difference between anybody who has a spinal cord in the very earliest stages and then anybody who's a mammal as we go on, right? There's an old saying, ontogeny recapitulates phylogeny. And that statement refers to ontogeny, which is the development from single fertilized egg to ready for birth. That's the ontogeny part. That development follows the steps that phylogeny followed, which is evolution. So you can see us going through the different stages of our, development through evolution, according to that old statement. I don't know if that statement's true. I have no idea. All I can say is it is hard to tell a rabbit from a human. That's all I'm going to say. Now, there are two principles of development that are going to start to be evident during the embryonic stage and that are going to continue up until puberty. So you're going to hear these phrases frequently through this class. So one of the principles is what's called cephalocaudal. So if you look at this drawing of this embryo on the left, you can see that the top part of it looks a lot bigger than the bottom part, the head part versus the rump, right? Cephalo is head and caudal is tail. Development is going to progress from head to tail. So we're going to see big stuff at the top, relatively smaller things at the bottom throughout development. And you're going to notice that throughout development all the way up until puberty, the head's going to grow before the rest of everything else. But also, we follow a proximo-distal pattern, which refers to the fact that the things from the center are going to develop first, and the things that are in the extremities. Proximo stuff will develop first, the distal stuff will develop later. So the extremities will develop later. So cephalocaudal, we'll notice that the fingers separate before the toes separate, which is what you see in the lower left picture, right? So that's evidence of cephalocaudal. But the fact that the heart and the liver and things like that developed before arms developed shows you that proximo-distal. So the arms develop before the hands, which develop before the fingers, that kind of thing. And we're going to notice that those are the principles of actually physical growth, but they're also going to be the pattern of physical, like motor skills, gaining control of those parts of our bodies. Here's an example of the size as we go through the embryonic period. So the dot on the very far left would be, a blastocyst at about the time of implantation. And then on the right, we have roughly the size of the embryo as it's moving into the fetal period. So really, really small, a lot of physical development going on in this little teeny tiny organism. Now, because so much growth and development is happening so fast, so many body parts are emerging and things like that, embryos are very sensitive to teratogens, or otherwise known as substances that interfere with normal development. Here's an example of what's going on at different stages in development. So we see in the left hand, those two columns, they're labeled the germinal period, and that's from conception until implantation. And so you're going to notice there are no highly critical, which are labeled in the orange, or purple, less critical periods happening during the first 2 weeks, because during the first 2 weeks after conception, the blastocyst hasn't implanted yet, therefore it's not consuming anything from mom's body, and so that means that the little blastocyst is inside of its own little shell, consuming its own little nutritional package, and living on its own. So there is no exposure to teratogens during that period of time. Now, there are things that could be happening in mom's body that would make it impossible for that little developing blastocyst to implant. That's different. The hormonal things or exposures to toxins and things like that could make it so that her uterus can't house that developing blastocyst. But that's different. That's not a teratogen. That's something else. So the teratogens are going to start to have their impact on a developing embryo once implantation has occurred. Now, the orange areas are what we call highly critical periods. That means that if you are exposed to certain teratogens during this period of time, it's going to have a really high probability of having an impact on the developing embryo. Another way to put it, though, is the absence of certain things during a highly critical period can cause the failure of certain things to develop. So highly critical periods are times when certain kinds of circumstances must be present or absent in order for healthy development to proceed. The purple areas, in this chart, they label it less critical. Some people call them sensitive periods, where for some developing embryos or fetuses, these might have an impact. So it's a lot less clear what impact a teratogen might have once we move into those purple areas. Once the purple area is over and we're just seeing that blank white background, that means that part has finished developing, and so no longer could a teratogen interfere with it. Okay, so let's look at what's going on during these different periods of time. So we see the main embryonic period being weeks 3 through 8, and then we see the fetal period being weeks 9 through 38. And then along the left-hand side, we see the different systems that are developing. The central nervous system at the top, the heart, the arms, the legs, the lips, the ears, the eyes, the teeth, the palate, and the sex organs are all developing during these stages. And you see the orange periods for each of them. So, for example, the central nervous system, it has a very long critical period. The central nervous system includes the brain and the spinal cord, and there are a lot of things that could go wrong during that phase. During the first 6 weeks after conception, neural tube defects may occur in the presence of certain kinds of teratogens. Neural tube defects are what you might call spina bifida, where you have a spinal cord that is not necessarily surrounded by vertebra. And so at birth, that baby's spinal cord might be vulnerable to pressure, making them more likely to become paralyzed. Or their spinal cord might actually even be not surrounded by even skin. And so sometimes babies with spina bifida will be born with exposed spinal cords. So those kinds of neural tube defects, there's a genetic component to that, but it also could be an outcome of exposure to certain kinds of teratogens like radiation or certain kinds of toxins in the environment, or most commonly it would be the lack of exposure to folic acid that could cause neural tube defects. So I'm trying to focus on the teratogens right now, but there are also dietary things that have been connected to neural tube defects. Mental retardation, which is not a super popular term in lay people's conversations, but it's a very specific diagnosis where a person has an IQ below 70. And it is more common among people who have had exposure to teratogens like alcohol during this period of time between week 3 and week 16 in particular. You can end up with really profound effects. Learning disabilities are more common when you've had exposure to teratogens after week 20, something like that. So the brain is really picking up steam in developing neurons and organizing itself from about week 16 through about week 24. And so exposing yourself to radiation, alcohol, cocaine, those kinds of teratogens can actually significantly impair the developing central nervous system. You guys might be familiar with the Zika virus fears that occurred a couple of years ago, where babies were being born with microcephaly. The hypothesis is that the Zika virus was a teratogen that was interfering with the development of the central nervous system. So while all the other body systems looked fine, the actual back of the head was sort of collapsed because all that brain development didn't occur that was supposed to be occurring during those weeks. So there are a lot of different kinds of teratogens, right? I've mentioned a number of them, right? We've got radiation, we've got intoxicants that mom might consume, we've got viruses, certain kinds of bacteria. If we hop down to eyes, this is a virus. If mom's exposed to German measles, it's called, during a critical period in fetal development, it can interfere with the developing eyes and the baby can be born blind. So it's one of the reasons why moms are encouraged to have up-to-date vaccines, because being exposed to something could then end up with long-term outcomes for the baby. There are things like antibiotics that mom might be prescribed during the 6th or 7th or 8th week of gestation. A lot of times moms don't even know they're pregnant during that period of time, and certain kinds of antibiotics can cause permanent staining of their teeth, of the baby's teeth. So there are different kinds of things. Some of them are things that we don't know we've been exposed to, like fertilizers. The phthalates that are present in fertilizer have been associated with interference with the developing sex organs of babies. So they're, ranging from fertilizers all the way up to, taking it on purpose as a recreational consumer, things that could happen to the fetus or the embryo as a function of being exposed to these different kinds of teratogens. Let's move on to the fetal period. Now, in this slideshow, you can't see this video, but it's one of the ones that I have listed in the classroom that shows what's going on during fetal development. Really common during the fetal period for expectant moms is to get an ultrasound. Some moms will be given an ultrasound earlier on in like the 9th week to establish the presence of the fetus in the actual uterus. So oftentimes an ultrasound is conducted very early in the fetal period, which begins at week 8, to ensure that the fetus is where it belongs and that it's developing an amniotic sac and that all the things that it needs, are that its heart is beating and those kinds of things. Then oftentimes there will be another ultrasound sometime later. A lot of times the parents regard the second ultrasound that will occur somewhere around 20 to 24 weeks. They often regard that as the opportunity to see what sex their baby's going to be. But from the medical perspective, the purpose of the second ultrasound is to ensure that all the limbs are present, that the brain is developing as it's supposed to, that the heart is okay. They measure the size of the abdomen, the size of the head. It allows them to make a better judgment of the likely due date. They assess the volume of amniotic fluid. They look for all sorts of things that are signs of potential trouble down the road. And so while the parents may be just super excited to find out what sex the baby's going to be, the second ultrasound appointment usually takes a while as the technician is doing all these measurements and looking for different things. Brain development during the fetal period is really ramping up. The fetal period, by 25 weeks, fetuses can recognize sound. Now, we can't give them a test to know if they know the difference between a dog barking and doorbell ringing. We have no way to know that. All we know is that certain sounds can cause reflexive responses from the fetus. That's all we know. So a startling sound can make a fetus startle. That's all we really know. But we know that they can hear and physically react to what they're hearing. So that's led a lot of people to wonder, well, if they can hear stuff and they can react to things, can we teach them some things? Can we get a head start on education with our little fetus? I put a question mark there because it's a topic of debate. Most psychologists have fallen on the side of A, you can't really teach a fetus anything, and B, you probably shouldn't try to, but it may not be a good idea. So let's start with my A point. Probably can't. I'll just give you a really great example of something that we all naturally do when pregnant, which is speak, and yet babies can't come out speaking. How come they don't learn what we're talking about while they're in the womb? When I was pregnant with my second child, I was teaching, and so I would talk for 5 hours a day every single day of the week for the entire 9 months I was carrying him. And oddly enough, he did not seem to A, speak English when he was born, or B, know anything about psychology. It's really, he's like the worst student ever. He didn't pick anything up. But it's possible that while they can hear and they can reflexively respond to sounds, they may not have the cognitive mechanisms in their heads yet to actually incorporate and store anything. It's one thing to have your ears working. It's a whole other thing to have the cerebral cortex set up and ready to learn. So that's my A point. Can they learn anything? My B point was, should they be learning anything? Some people have made an argument that, human infants or fetuses spend 9 months inside of the womb for probably a reason. Other species have, embryos that crawl out of their moms and get inside of a pouch and start having experiences, long before human fetuses would have experiences. So why are the human fetuses kept inside for so long? And some people argue that it's to keep them from being exposed to stimuli and things like that, so that the normal pattern of development can progress without interference or with minimal interference from the environment. So I don't know. All I know is my son didn't learn anything. I did provide for you in the classroom a prenatal learning video that you can check out, and you can answer this question for yourself, I guess. All right, what about the effects of hormones? I have a video in the classroom for you about, whoops, sorry, this is reanimating. There you go. A video in the class about the effects of hormones, prenatal hormones. The thing is, just to give you the encapsulation of its contents, the biggest effect of hormones seems to be the exposure or the absence of testosterone during fetal development. During the first 9 weeks after conception, the male and the female embryo are exactly the same. They're just doing their thing. And about 9 weeks after conception, the Y chromosome from the male embryo causes a burst of testosterone to be released from the adrenal glands. And that triggers the development of the external genitalia. Okay, so in the presence of testosterone at the critical period when genitalia is going to develop, causes external genitals. In the absence of that burst of testosterone, you get the internal genitalia of the female. Typically, the Y chromosome carrying individual has that burst of testosterone, and typically the XX carrying individual does not have that burst of testosterone. So typically, external genitalia are associated with the male chromosomal pattern, and the internal genitalia are associated with the female pattern. But sometimes those patterns can get interfered with based on malfunctioning adrenal glands that might cause a burst of testosterone in an XX carrying baby during that critical period of development of the sex organs. And so you can get what's called a masculinization of the sex organs. These are not sex organs that have switched sex. You don't have a person who has an XX pattern and now has fully functioning male genitals. All you have is what's called a masculinization. So you may end up with an individual who is what we call intersexed, where it's difficult to tell whether what we're looking at is male or female genitals. The same kind of thing can happen to males, XY carrying individuals who are insensitive to androgens. And so when their adrenal glands release testosterone, their body may not respond to it. And so they may not masculinize their genitals. So just having an XX or an XY does not guarantee that you'll have internal or external sex organs. The other thing about hormones, though, that's really interesting from a psychological perspective is that there is another burst of testosterone that happens in the XY carrying individual on average between about 20 and 24 weeks after conception. And for a long time, researchers didn't know what the function of that second testosterone boost was, but now researchers are homing in on it and realizing that it seems to masculinize certain structures of the brain. So that in the male, the XY carrying individual who gets that burst of testosterone at the critical period for brain development will end up with, for example, a larger amygdala, which is the structure that determines our feelings of aggression or fear. In a XY carrying person who's gotten that burst of testosterone, it tends to be larger. And that may be associated with higher rates of aggression. And we're going to talk about that later when we get to childhood. In the absence of testosterone, the corpus callosum, the band of fibers that connects the two hemispheres, grows larger. And so females typically have larger corpus callosum. The two hemispheres develop differently based on exposure to testosterone or not. So that females, in the absence of testosterone, tend to grow larger left hemispheres and bigger verbal areas. Males tend to end up with right hemispheres that are roughly the same size as their left hemisphere, and that helps to fuel their spatial abilities. Those are just a few examples of the dozen or so different brain structures that are noticeably, measurably different on average between males and females. That's super important to remember. I keep saying on average really with great emphasis. Read that as bold writing. Because while there are on average differences, that does not mean any one of you listening has the pattern I'm describing. It's just on average what's going on. So hormones seem to have their biggest impact prenatally on the development of the sex organs, and then later on the sexual dimorphism, or the sexual differentiation of certain structures in the brain. All right. We'll come back to a lot of these things as we start moving through development. That's why I'm moving through them kind of quickly at this point. The birth process, always good fun. Everyone enjoys a good birth process. On average, for the average first-time mom, labor will last approximately 12 hours. Now, one of the things that can cause a lot of variation between women is their sensation or their determination that labor has begun. Some women feel like labor begins the second they get any kind of sign or symptom that they might be in labor, and they're like, okay, I'm in labor. And then even if things slow down, or if that was a mistaken sign, they still will say, that's when I started labor. And they'll say, I was in labor for 72 hours, when a person who was observing from the outside might be able to say, well, really, honestly, you didn't start the real process until 12 hours ago or 20 hours ago or something like that. So a lot of it's in the eye of the beholder. A lot of us, labor differently or perceive pain differently. And so this is just sort of an average. Now this is, I was going to say cut in stone, but that just seems like too on the nose. So this is hard and fast. I don't know if that sounds wrong either. Anyway, stage 1 is dilation. So we know that the first stage of labor is the dilation process. This is the part that really seriously hurts. You might think stage 2 is going to be the painful part, but stage 1 is the part that hurts. I thought I had some pictures of different dilation sizes, but apparently I don't. So when labor begins, before dilation has started, the opening of the cervix is what we call 0. So it hasn't started to open up at all. And it needs to get to 10 centimeters of dilation. And typically this is going to occur in about 8 hours of this whole labor process is going to be devoted to dilation. So in about 8 hours, you go from approximately 0 to 10 centimeters. 10 centimeters, if you happen to have had a bagel this morning for breakfast, is about the diameter of an average bagel, or Thomas's English muffin. I'm trying to think of other things that are spherical or round that are approximately 10 centimeters. Donut. So it's not negligible. Let's just put it that way. It's larger than you might think that the cervix has to open, right? And the process of opening the cervix is reliant on the contracting of the uterine muscle. The uterus is one gigantic muscle layer on the inside, and when it's time for labor, and it's not clear what triggers the timing for labor, it seems to be something that comes out of the baby and crosses the placenta and is picked up by the mom's uterus. But one way or another, the message gets sent and the uterus starts contracting. And the first stage of dilation, the uterus is contracting on the sides and sort of trying to pull back the opening of the uterus. Then it starts focusing on the top of the uterus and starts pushing down. And that's what's going to cause the cervix to really thin out and really back up and get out of the way. Once the cervix is completely out of the way, the next stage of labor is going to be delivery of the actual baby. So in this picture, you can actually see some of the things I've been talking about labeled. So you see where the cervix is. That's the opening of the uterus. And in the picture on the top left, the cervix hasn't begun dilating or effacing yet. So it's still thick and it's still closed. By picture B, there in the middle top, you can see that the cervix has started to pull back and thin out as the baby's head is pushing downwards to get ready for delivery. And then by C, the cervix is completely open and the baby has started to descend down into the birth canal. And then ultimately, the baby is delivered. You'll notice that in picture B, this is a nice baby who loves its mother because it's coming out face down. So its nice, soft little face is what is coming in contact with mom's spinal cord or her vertebra. Mean babies come out looking upwards and their bony heads are making pressure on mom's spinal cord or vertebra, and that causes what we call back labor, and that really hurts. And then we see the baby exiting mom in letter E there, and it does. It's a trick getting what is clearly too large of an object out of this this orifice. So a lot of times, one of the reasons why we deliver in hospitals is because it takes a lot of twisting on behalf of the doctor. So that the face can come out in one direction, and then you sort of have to twist it to get the shoulders to be in another direction. Once the shoulders have cleared, pretty much everything else, because of cephalocaudal development, everything else below the shoulders is pretty small, and it just sort of comes on out. So that's stage 2. Stage 3, you might be thinking, well, what can possibly be left? The baby's been born. But nope, there's one more thing that has to come out, and that's the placenta. The placenta weighs about 1.5 pounds, 2 pounds, something like that. So the average baby is about 7 pounds. The average placenta is about 1.5 pounds, 2 pounds. So it's not something that you wouldn't want to, deliver. And generally the uterus contracts and expels it just like it did the baby. The placenta has been the connection between the baby and mom's uterus this whole time. And the placenta is all baby cells. So it's what implanted into mom's uterus and then grew out these little chorionic villi that allow transfer of nutrition from mom's bloodstream to the baby and oxygen from mom's bloodstream to the baby. And then from the baby will go waste. All the CO2 and waste products go from the baby's side and gets collected by the mom's bloodstream. There's no exchanging of blood directly. That's why babies can have different blood types than their moms, because they don't exchange blood. You might have heard that if the Rh factor doesn't match, that can be a problem. If mom is Rh negative and baby is Rh positive, mom's body may treat the developing fetus as an infection, and it can increase the risk of miscarriage. But otherwise, the bloodstreams don't intermingle. And the baby's been in the womb surrounded by an amniotic sac. And so that means that baby has been in there surrounded by all of its own cells. So all the way through pregnancy, baby has not had any direct contact with mom. It's just in there housed in its own little space capsule. And the first time baby's going to meet mom is at birth. So stage 1 is the dilation process. Stage 2 is the delivery of the baby. And stage 3 is the delivery of the placenta. Okay. Now, I have posted some videos in the classroom for you guys to watch that are warning scenes of live birth. It's always a good idea as you're going through any chapter called Prenatal Development and Birth, and you're clicking on any videos that have names like birth in them, that there might be a birth about to occur. I'll tell you that the ones that are labeled the drug-free birth, there you will see a birth. So when we're having babies these days, no longer do you go in there and the doctor will have you cured, right? Now you have to make a bunch of decisions about what your birth should be like. And so they call this a birth plan. I was discussing this with my daughter, what's your birth plan? And she said, for me and the baby to live through this. I'm like, okay, that is a completely reasonable plan. A lot of people go into birth with a picture of how it should go. And, every birth is different. All sorts of things come up. And so, moms need to be prepared for the fact that it could go in any direction. But some moms choose to labor and deliver without any kind of medication to dull the pain or anything like that. And there are lots of techniques to help with that. There are breathing techniques, there are meditation techniques, there are squatting positions or kneeling positions or using a ball or being in a warm tub of water, or there are a lot of different ways to achieve the goal. But you might say, well, and I've had a baby before, so I know what this feels like, but the second birth is not necessarily like the first birth, or the 8th birth is not necessarily like the first birth. So you never know what any individual delivery is going to be like. So setting a goal of going drug-free is a terrific goal, but also be prepared for possibly, something else might need to happen. When I had my children, I didn't have a goal to be drug free because I was aware that drugs are not necessarily going to be harmful to the fetus or to the baby who's being born. I was just a little creeped out by the different types. Like, for example, with Demerol, which is the most commonly used analgesic, this is usually used during the early parts of labor. And I had a problem with Demerol because sometimes one of the side effects is it can make you nauseated or make you throw up. And I will do just about anything, up to and including having children without painkillers to avoid throwing up. So I was like, yeah, I don't want to take that if I can avoid it. And it turned out very lucky for me that I didn't experience my dilation as painful during the period of time that they would have administered the Demerol. I mean, I felt it. I'm not saying it didn't hurt. I'm just saying I was like, okay, this isn't that bad. Okay, but then the next decision is whether maybe you're really super anxious, right? Maybe everything would be going better if you weren't like kind of freaking out. So sometimes you'll be administered a tranquilizer of some sort, like Valium. And neither one of these items that are on the screen right now really actually block pain. They both work by sort of taking your concern about the pain away. Like with Demerol, it's a narcotic, and so it basically makes you sort of a little bit high. Valium is, we use it as an anti-anxiety medication because it basically slows down your central nervous system so that, again, you're probably not worrying as much. So if you're really scared, a tranquilizer might make good sense. Luckily for me, I had been teaching child and adolescent development and human sexuality long enough. I wasn't completely freaking out, so that was good. And so yay. But then I thought, well, what if I want an epidural? And I have posted an epidural video in class, in the Canvas classroom, if you want to watch how they're administered and how you've got the person who went with the drug-free delivery versus the person who has opted for the epidural delivery. And so it's presented from two different angles. Basically, the procedure is to find that space between the spinal cord and the dura mater around it, and you put this anesthesia in there, and it numbs certain nerves. The old ones used to make it so that you couldn't even walk because you couldn't feel your legs, but now they are very localized, and they very specifically go after just the pelvic region so that you don't experience the pain as much. And I was just really, for me personally, I was really freaked out that, what if it makes my legs tingly for the rest of my life, which apparently it doesn't do. But I was more scared of the epidural than I was of trying to go drug-free. My goal was not drug-free. It was just like, I was hoping the stork was going to arrive. Let's be honest. I was hoping the stork was going to fly in and this was all going to be over with, and it did not happen. I'll just tell you right now. Spoiler alert. But anyway, the thing with the epidural is you have to make the decision early enough in labor that they can administer the epidural and have it start to take effect. And I made the decision too late. I was like, okay, I want my epidural. And they're like, yeah, you're like 3 centimeters too late, lady. So I missed my chance. So yeah, some of your birth plans may pan out and sometimes they may not. Things go however they end up going. But we do have different levels of medication. There's no reason for a mom to have to go without pain medication to be. Back in the 80s, they used to really hold it against women who used any kind of medication during childbirth. A good mom will go through Lamaze, and a good mom will, suck it up and whatever. We don't act like that anymore. A good birth is the goal. A birth where mom is not overly stressed is better for the baby than a birth where she's toughed it out to show some kind of, I don't know what that message was supposed to be about. So these are things that moms have to decide now. I was discussing this, now that my daughter's pregnant, my mom and I were talking about, our births and stuff. And so she was telling me about when I was born back in the olden days when women absolutely had no choice in what their birth was going to be like. And my mom said that she was given, she called it a spinal back then, kind of like an epidural, during the laboring part. And then when it was time to actually deliver the baby, they gave her what's called a twilight delivery, where they actually gave her anesthesia that caused her to go to sleep. She literally woke up later and everything was over with. And ta-da, you have a baby. So, we now are empowered and get to make choices that, our grandmothers didn't get to make. On the other hand, now you are empowered and have to make choices that, your grandmothers didn't have to make. So it's a double-edged sword, that's for sure. Another choice that you have to make is, where are you going to have this baby? Now, of course, this is a choice when, the delivery gives you enough warning that you get to pick your location. Some people just deliver, on the side of the road because they didn't make it. Things like that happen. But assuming you get to pick, okay. Some people choose to have their babies at home. It's a very small proportion of deliveries. It's like 0.04% of deliveries that are done at home. But it is a growing number. 125 years ago, like 98% of births occurred at home. And now we've flipped it till 99.6% of births occur in hospitals. So home is an option these days, with a midwife usually. Birthing centers are things that started to spring up in the 1970s that were trying to make birth more natural, much less, we will soon have you cured. But instead, this is a family event. And, the medical professionals are here at the birthing center. A lot of times birthing centers are affiliated with a hospital. So that if something starts to go wrong, then you get rolled down a hallway and now you're in the hospital. But you feel like you're in a much more normal setting when you're at a birthing center. And then finally, there are hospitals who now have to compete with birthing centers. So they've tried to make their labor and delivery rooms a lot more like birthing centers. So for example, the hospital where my daughter's going to deliver, they were telling us that they now have those same hot tubs that you can sit in. And my daughter said, well, I'm already so hot. Why would I want to sit in hot water? And they said, you can make it lukewarm. You can do whatever you want. And so I asked my daughter's very sweet and lets me go to the prenatal visits with her. So I asked the nurse, well, are you allowed to deliver in the hot tub? Because in a birthing center, you can deliver underwater. But hospitals historically have frowned on that. There's, concerns about contamination, other kinds of things. It's not a concern about the baby drowning, by the way, because the baby is currently swimming in amniotic fluid. And so if it's delivered underwater, it doesn't take its first breath. It doesn't attempt its first breath until its face feels air on it. And so it's not going to breathe just because it's left the mom's body. It needs air on its face. So I asked, can you deliver in the tub? And she said, well, we don't plan for you to deliver in the tub. We don't encourage you to deliver in the tub. But if it happens, it happens. And she says, I've delivered some babies in the tub. So hospitals have gotten a little bit more open-minded. Hospitals have been very concerned about hygiene for a long time. And so, dads used to be put in little booties and little, scrubs and a hat and all these things. And mom used to have her pubic hair removed because it might be contaminating and all these things. And moms used to be subjected to, oh my gosh, I'm blanking on the word because it's just so horrifying. Oh my gosh, I'm completely blanking. Because I want to say epidural, but that's not the word I wanted to say. Enema. Oh, thank goodness I thought of it. Enemas, where they would flush out mom's, lower intestines so that during delivery, the baby wouldn't come in contact with it. A lot of those kinds of things. Today, they realize all of this is very natural. All of this is very normal. And so you don't have, none of those things that I mentioned happen anymore. In fact, now they're starting to realize that when babies are born, they're covered with this white goo that, our natural inclination is white goo cannot be a good thing to have on your newborn. Wipe that stuff off, right? It seems gross. A lot of times there's blood mixed in with it, and so, that makes good sense to wipe off. But now we realize that white goo, which is called vernix, is actually a protective layer that helps. It's got antibiotic properties that helps to protect the baby's skin from the outside world. It actually helps to keep the baby moisturized. It's like putting lotion on the baby. So now they're realizing, okay, don't wipe it all off. I mean, there are a lot of things that people figured out through home births and birthing center births that now are being applied in the hospital. So the hospitals are getting more and more people-friendly. But boy, you can tell in the picture of the hospital, if something goes wrong, they are ready to step in at a hospital, whereas the other two settings, you're going to have a little bit more delay. The birthing center is going to be closer to a hospital. At home, you know how far you live from a hospital. And a lot of times you're looking at it, calling the ambulance and then riding. And so it can be a little bit of time. So it's a little bit riskier the farther you get away from a hospital. Another big birth choice that has become, something new since the 70s was dad being at the birth. they used to think dad might freak out or faint and we don't need him in here. And, of course, hospitals oftentimes have a, that seems like a lawsuit waiting to happen kind of attitude about things. And so for a long time, dads were sort of prohibited from being in the room. And then for a long time after that, he wasn't allowed to take pictures or record anything, again, probably because of lawsuits or other things. Hospitals now are realizing dads are an advantage, and that documenting this birth is an advantage. It's not an advantage in the way that you might be thinking. In fact, a lot of dads wanted to be in the delivery room because they thought that they were at a disadvantage, kind of following that Conrad Lorenz idea that imprinting happens at birth. And so they thought they were at a disadvantage. Mom gets to meet the baby right away, and dad's out in the hallway waiting, some amount of time afterwards. But it turns out it doesn't matter whether dad's present or not. It doesn't affect the bond with the baby. Definitely does not affect the baby's bond to the dad, that's for sure, because babies don't imprint immediately after birth. The biggest advantage to having dads in the room is the improved bond with mom. If you ever watch any of these kinds of, Expecting is a new show on Up. They used to have a baby story on TLC back in the old days. If you ever watch any of those things where a mom has legitimately just given birth to a baby and the dad was present, dads are blown away by the delivery of their baby. Most dads, after watching the birth of their baby, report it to be a peak life experience, something that they will carry with them forever. They respect the mothers of their children so much more after watching them give birth. So and then it also helps to activate their protectiveness, that natural tendency to want to take care of their, the mom and the baby. And so that's a real advantage for the family unit. And so dads being there are a huge advantage. Now, if anybody's listening and thinks, well, I'm going to drag my male partner into the delivery room, even though he has expressed that he doesn't want to be there, I just would like to warn that sometimes dads see stuff in there that they probably shouldn't see. And some dads, if they're already nervous, might not be the best candidates for being birth coaches, because they might pass out, or they might see stuff in there that makes them a little nervous about ever having sex with their female partner again. They might be like, okay, that's it. I'm never doing that to you again. That was horrible. So you never know which way someone's going to react. But if they're giving you big signs, like, I don't want to be there, that kind of implies that maybe they shouldn't be there. And so a different coach might be a good idea. Now, having dad there for the labor part is an advantage to the mom, because she tends to have a shorter labor as a result. Having somebody there who can advocate for her, call the nurse when needed, get ice chips, rub their back, those kinds of things can be a real advantage. And it really reduces the reliance on drugs. Moms can delay the onset of pain medication longer than they probably would have if they were there by themselves and maybe a little scared, more scared. So those are big advantages. But I'd like to point out the shorter labor and the reduced reliance on drugs is true with any birth coach. So those two things, probably you don't need it to be the dad to get those advantages. It could be a professional birth coach. It could be, a friend or a mom, or anybody could be helpful with that. We're really struggling. I'm internally struggling with my daughter's invitation to be in the labor room with her, because I really don't want to interfere with what should be going on with her and her husband. And so I'm like, I want to be there, but I don't want. So I'm trying to figure out how to act. Trying to figure out what is my job and how do I not do the wrong stuff. And I'm not sure how I'm going to handle seeing her in pain. So I'm going to have to be really aware of what I'm feeling like and get out of there if I'm possibly interfering with what should be going on with her and her husband. So I'll update you after that happens. Only if I come out looking good. If I come out looking bad, I'm not saying anything about it. Now, the baby's been born, and being the good Americans that we are, we're going to give you your first test. Yay! We're not going to even give you 1 minute of life before you get to experience your first test. It's called the Apgar test. You get to take it 1 minute after birth and then again 5 minutes after birth. And here are the critical criteria that they're looking for in the Apgar scale. And you get a score of 0, 1, or 2. 0 is bad, 2 is terrific. And so we're measuring you on 5 different vital signs. Your color, if you're blue or really pale, that implies anoxia, so that's a score of 0. If your body, right, the proximal areas of you are pink, but your distal areas, your extremities are blue, then you get a 1. If everything's nice and pink, then you get a 2. If your heartbeat is absent, 0. If it's just slow, if it's below 100, because you just went through something very stressful, right, being delivered. So we're expecting you to have a rapid heart rate. If it's below 100, that can be a bad sign. Reflex irritability. So you might be familiar with, the old adage that they spank a baby at birth to make them breathe. They don't spank babies anymore, but they flick them on the sole of their feet, or they give them a little puff of air on their abdomen. They're looking for one of their reflexive tendencies. If they don't respond at all, that's bad. If they cry in response to the flicking on their feet, or they sneeze as you blow on their face, things like that. If they are spontaneously coughing, any of those things, that's the top performance. Muscle tone, that would be moving around the body voluntarily, and it's usually the arms and the legs, right? And then respiratory effort. Crying is a really good sign that you're breathing, right? So, because you got to get breath in there to be crying, but you don't have to cry in order to get the 2. You could be getting a 2 just by breathing reliably. But if you're breathing irregularly or you're not breathing frequently, then that's that mid-range. So of course the scores range from 0 to 10, and anything above 7, this is a really healthy, great baby, good to go. If you're lower than that, we're concerned about what is pulling you down, and then they address those things. If your score is less than 5, they're really going to assess you and possibly take you off to the NICU. I remember when my son was born, his body was nice and pink, but his fingers were blue, and his forearms on the underside were blue, and so the nurses gave him a 1 for that, and I was like, oh, he didn't get a 10, because being the good helicopter mom of the future, I was like wanting him to get a perfect score. Well, when we got home and he started pinking up and all of his normal stuff started happening and everything, I noticed that it wasn't that his forearms were blue. He actually had bruises on his forearms. I don't know why his forearms were bruised. I'm sure it was something having to do with getting out. But anyway, when I took him to his first prenatal visit, I was like, well, I'd like to update that Apgar score, because his forearms were blue because they were bruised, not because of lack of oxygen. They're like, yeah, it pretty much doesn't matter now that he's 2 weeks old. But it's so funny how competitive us parents. I don't know if you guys are this competitive, but I did not know I would be. I was like, why'd you take a point off? Stupid stuff. All right. So there are some problems that can occur at birth, unfortunately, and one of them is the need for a cesarean section. C-section is oftentimes the term we use. It's going to be necessary in these circumstances for sure, where the baby is not head down. Either it's transverse, which is what you see in that top left, so the baby's completely sideways, or in the bottom left, you see the breech position, where it could be, it's usually going to be its buttocks coming first, because babies tend to be in that fetal position with the legs all curled up, but it could be legs first. Anyway, either way, it's for sure in the transverse position, the baby cannot be delivered in that position. In the buttocks first position, it's a little trickier, because maybe the baby will make it up, but we're not sure, because if we deliver the body and then we're going to come up against the hard jaw that can't collapse like the top of the skull is designed to do, the baby could get stuck. And so if the baby can't be turned, which sometimes you can palpate from the outside, and the baby will turn and stay in that position for delivery, and you're okay. But if the baby can't be turned and it's staying in that buttocks first position, oftentimes that's going to be an emergency C-section. Now, on the top right, you see what's called placenta abruptio, and that's where the placenta has separated from the uterus before the baby has been delivered, and so now the baby's being deprived of oxygen. And then placenta previa is where the implantation of the blastocyst had occurred too close to the opening of the cervix. So everything was fine during pregnancy, but now that it's time for delivery, the placenta is going to come out before the fetus. And again, you're going to be deprived of oxygen. So in these cases, these are completely required. There are a few other completely required cases. Active herpes infection. You don't want a baby to pass active herpes sores, because the baby can contract herpes, and it can be a life-threatening illness in a baby. Fetal distress, its heart rate is going down, its umbilical cord's wrapped around it, something like that. A lot of times if there are 2 or more babies in there, they just have to opt for a C-section because maybe one's up, one's down, or we're not sure if they're going to, take turns coming out one at a time. So, C-section is very common. Maternal distress, she's got too high of blood pressure or something like that. But what we're seeing today is a controversial rise in rates of C-sections that are not necessarily tied to a commensurate rise in these kinds of necessary circumstances. Some moms are opting to schedule a C-section without, even considering a vaginal birth. And I mean, when I first started teaching this class, the C-section rates were at about 22%. And we thought, that seems a little high. It seems like probably more like 10% of deliveries would require a C-section. So what's going on with these extra 12%? Well, today we're at about 30% of C-sections. So why are a third of moms having C-sections? And one explanation is that moms are getting older. The older you are at delivery, the higher the likelihood of a C-section. It's harder on the mom's body to go through labor, and so you might get that spike of blood pressure, things like that. So part of it is probably attributable to increasing maternal ages. Another factor is that babies are getting bigger. Babies had hovered at around 7 pounds as the average size at birth for about a century. And then now it's up to about 7.25 pounds at birth. Now that doesn't sound like a huge change. That's, 4 ounces more. But that means that there is a large increase in like the number of women who are giving birth to 10-pound babies and bigger. That's a big baby. That is probably not making it out the normal route. And so you're looking at needing C-sections. And so we're looking at, well, why are we having these spikes in really big babies? And one factor is the spike in gestational diabetes, where women are not processing sugar properly while they're pregnant. It's not they are not diabetic in their normal everyday life, but while they're pregnant, they're experiencing these blood sugar spikes. And it's causing babies to gain a lot of weight. So these kinds of things, I know, 22 years ago is when I had my last child, and my gestational diabetes test had involved drinking this just hyper sugary drink and then waiting, I don't know, an hour, some torturous thing they make a poor pregnant woman do. And then they collected my urine and looked for protein. My daughter just had her gestational diabetes test. She had to fast for 12 hours, which is really mean to do to a pregnant person. Then she had to go down to the doctor's office. They drew her blood. Then she drank the sugary drink. Then we sat there for an hour. They drew her blood again. And then we had to wait 1 more hour. And then they drew her blood again. So they're so concerned about gestational diabetes, and they're trying to catch it early because they're so concerned about the size of babies. So big babies, older moms, that rise in multiple births that I mentioned before, as women are using more fertility treatments that include spurring ovulation, that's causing us to have more multiple births. But then we also have the rise in malpractice lawsuits, where if something goes wrong during delivery, doctors get sued. And so they are opting for C-sections that in the past they might not have done because they knew it was hopeless and it wasn't going to work anyway. But if they don't do everything they possibly can, they're open themselves to lawsuits. And then we also have the smaller number, but something that, people shouldn't be doing, which is just choosing to have a C-section because they just are too posh to push. And, a C-section is a big invasive surgery and a big recovery. And so if a woman can avoid that, it's to her advantage in the long run. And it's to the baby's advantage. They now realize that during delivery, babies are exposed to bacteria and other kinds of things that are good for their immune system in the long run. And they don't get during C-section births. So it's definitely controversy and something that is probably going to plague us because women are getting older as they have their first births. Now, another problem at birth is birth size. I just got done talking about we don't want you too big, but definitely don't want you too small. So here are 3 babies. On the right-hand side is an average size 7-pound newborn baby who looks gigantic, right, compared to the other 2. But these are babies who are low birth weight in the middle. That means that the baby is less than 5.5 pounds, but more than 3.5 pounds. At 3.5 pounds is the cutoff for the very low birth weight baby. Things that cause low birth weight and very low birth weight would be being born early. That's the number one cause. But of the ones that are full-term babies that are small, prenatal malnutrition is a really common cause. And so you might be thinking, well, the baby doesn't eat, so what are you talking about? Well, some of it is because mom didn't get enough to eat during pregnancy, or maybe it wasn't healthful food that she was consuming during pregnancy. But it also could be problems with the placenta, where there wasn't enough transfer of food during pregnancy. Like, one of the things that can contribute to prenatal malnutrition that's not about what mom eats, but is about what she smokes. If mom smokes cigarettes, it constricts the blood vessels that are going to the placenta and deprives the baby of oxygen and of food. And so we see smaller babies on average among women who smoke. So what kind of effects do we see from being really small at birth? Well, at birth, they're less responsive, for sure. And so you're going to get lower scores on the Apgar scale and things like that. More likely in the prenatal period and through infancy to have respiratory, I'm supposed to say respiratory and cardiovascular distress, but apparently I left cardiovascular out of my typing. So respiratory and cardiovascular distress. So they're more likely to have heart problems, more likely to have breathing problems. As they are growing and developing, they may be behind the normal motor development charts, milestones. They're more likely to die during infancy, between birth and 1 year of age, from things like sudden infant death syndrome, much more common among babies who are low birth weight or less. Also more common among babies whose parents smoke, so there may be a little bit of interaction there. But they are less likely to make it out of the infancy period. So let's talk just about the newborn period, where we've been born and now up to 6 weeks of age. Different textbooks cluster it by birth to 4 weeks or birth to 6 weeks. I'm going to give the babies, a full 6 weeks of the newborn phase. So when babies are born, they have a set of reflexes that they're equipped with. These are behaviors that must be performed given the proper stimulation. So this is not something that's learned. This is something that is pre-wired and the baby has to do it. There are two main kinds. There are the adaptive reflexes, and then there are the primitive reflexes. So when we look at the adaptive reflexes, we're looking at those kinds of things that babies naturally do. They didn't learn them. They just do it with the proper stimulation, and they really help to ensure survival. So here we have this baby who's getting ready to suck on that lady's nose. Sucking is an example of an adaptive reflex. If something is in the baby's mouth, whether it's a bottle or a breast or a pacifier or a finger or a nose, the baby has to suck on it. That ensures their survival. They can't help it. If something comes out of whatever they suck on, because it's a bottle or a breast, then the next adaptive reflex will kick in, which is swallowing. They can't help it. Another adaptive reflex that babies are born with is crying. If they experience any kind of discomfort of any sort, empty stomach, something poking them, too hot, too cold, anything like that, they can't help it. They reflexively cry. They're not doing it on purpose. They have to cry. And that helps to ensure that they'll have their needs met, right? If it's too hot or too cold, mom can fix that. If they're hungry, mom can fix that. If something's poking them, mom can fix that. It helps to ensure that they'll be cared for. The primitive reflexes are reflexes that are some kind of evolutionary throwback. There's really no benefit. It doesn't really do anything for us. In fact, some of them seem like they might be counterproductive, like the tonic neck reflex, where if you start to let the baby's head go backwards, it causes their whole body to go rigid. That may have been helpful at some point in our evolutionary past, but today, with us being naked primates with no hair for them to hold on to, if their body becomes rigid, they become hard to hold on to. They become difficult, and you juggle them a little bit. The grasping reflex is displayed when you hit them in the palm of their hand. Their fingers will roll around whatever you've put there. Here we have a finger, a rattle, whatever you put there, they'll grab onto it. And it's kind of cute because parents go, wow, look how strong they are. They're holding so hard, their knuckles are white. Or if you do it to both hands at the same time, you can actually lift a newborn off the table with their own grip strength. And this, again, might be an evolutionary throwback to when we were covered in hair and our infants needed to hold on. The step reflex if you take a newborn baby and you put them on a firm surface, not your lap, but like a table or something, and you support their weight, and then force their little leg to straighten out. This is tough when they're really brand newborns. They really want to pull those knees up. But if you straighten out those little Achilles tendons on the back of their heels, they'll start to alternatingly step one foot then the other, and a really like primitive stepping behavior. Some people think this is a sign that sometime in our evolutionary past, our babies were able to get up and move like other mammals can. The crawl reflex is when you put a baby on its stomach, even though it can't move yet, it makes a lot of the alternating arm and leg movements that are later going to be beneficial for crawling. Now, obviously, this baby in the lower right-hand corner is not a brand newborn. This is probably a 4-month-old who can hold up its little, a 4-week-old, sorry, that can hold its little head up. But the squirming kind of looks like, a precursor to crawling. And this is probably something that they were encoded with that, was beneficial when we were, ancestrally, that was beneficial. Babies also have perceptual skills. I already mentioned before that, the ears are wired up by 25 weeks in the womb. At birth, babies have I think I've got that backwards. I think it's 2,200. They can see at 20 feet what we can see at 200 feet. Now, some of us, I mean that with our glasses on, but you know what I mean. So they are like legally blind, but they're not blind. They see best within about 6 inches of their face, which is about where we tend to hold them when you hold a newborn, right? You put them in the little crook of your arm and you study their little faces and you hold them up and study their little faces. And we hold them at exactly the correct distance for them to actually be able to see us. Of course, they don't focus on what you might expect them to focus on in things, but they can see just really up close. They can recognize their mom's voice. Now, I questioned whether you can teach your baby anything in the womb. One thing that they do pick up from having been exposed to sounds since their ears got wired up is intonation and, the timbre or timbre, I don't know how to pronounce that word correctly, of their mother's voice. They can't hear what she's saying. It's very muffled. There's a lot of digestion noises and other gurgles and things going on inside the stomach. So they can't really hear what she's saying, but they can hear her style of speech. There was a study conducted on newborns of moms who speak German versus newborns of moms who speak French. The German language tends to drop off at the end of sentences, and the French language tends to go up on sentences. And what they found is that babies could recognize speech patterns that were appropriate to the language they'd been exposed to. So they turned their heads towards the sound of whichever language their mom had spoken. They also can recognize their own mom's voice. So if mom's not in the room, they have speakers, one on either side of the baby's head. And out of one speaker, mom says, "Hello, baby," or other words. And on the other speaker, somebody else does that. Baby will reliably turn their heads towards the speaker that has mom's voice. And usually within 3 hours, we can test a newborn and establish that the newborn recognizes mom's voice. Dads can improve the likelihood that baby will recognize their voice by reliably, like every single day, spending some amount of time talking to the stomach. But you really can't compete with the baby hearing mom talk as much as mom talks. Perceptually, babies prefer sweet and salty tastes to sour tastes, and they absolutely just will recoil like you've given them poison if you give them something bitter. So they absolutely prefer sweet and salty. Coincidentally, mom milk is really super sweet. Some people have compared it to the taste of cantaloupe juice. And then, a lot of times mom tastes salty. So you can imagine that it might be to a baby's advantage to prefer the very flavors that they're likely to experience as they're doing that adaptive behavior of feeding. They can recognize their mom by scent. Now, remember, baby did not get exposed to mom's scent during gestation. Baby was in its own womb, right? And so its own little amniotic sac and all those things. And so the first time baby meets mom is during delivery. That's the first whiff of mom that baby gets. Babies can recognize their mom's scent within an hour of birth. Okay, but here's something really weird, because they did a study where they let new moms interact with their newborn for 1 hour, and then they removed the newborn to the nursery or the mom interacted with the newborn for 5 hours, and then the newborn was removed to the nursery. And then the mom was shown pictures of an array of 5 babies, one of whom was their own, and they were supposed to recognize their babies by face. And the moms who had spent only 1 hour with their newborns worked at exactly the chance level. They could not recognize their babies from an array of 5. The moms who had spent 5 hours could. So we think it takes about 5 hours for a mom to get the visual of what their baby looks like. But here's what's really interesting. So they took those same moms, and not only did they show them the pictures, but they gave each mom 5 bags. One of each contained a little t-shirt that the newborn had been wearing. So one of the bags contained their own newborn's t-shirt. The other 4 bags contained somebody else's newborn's t-shirt. And the moms smelled the t-shirts. And within 1 hour, mom could recognize her own baby by smell alone. So she might not know what her baby looks like, but she knows what her baby smells like. That's kind of interesting, because you wouldn't expect necessarily, a full-fledged adult human to sort of get that kind of animalistic kind of reverting to smell, but we do. All right, during the newborn period, babies are on what we call an ultradian rhythm. You guys operate on a circadian rhythm where you have big blocks of sleep, big blocks of wakefulness. You eat in amongst that block of wakefulness, stuff like that. Newborns are on an ultradian rhythm, more like a cat, where they complete an entire cycle of sleep, wake, and eating within about 1.5 to 2 hours. The younger babies do it even faster, right? So they go from deep sleep to lighter sleep to kind of fussing to hunger to alert wakefulness, and then immediately back into deep sleep. And they'll repeat this cycle every 1.5 to 2 hours throughout the day. They, of course, have no idea what's day and what's night in their world. They've been in the womb, and so they're not familiar with day versus night. So they'll be doing this the whole time. They don't sleep more at night than they do during the day, like we would like them to do. But they do, across the day, sleep 15 to 16 hours. So that's why they tell new moms, sleep when the baby sleeps, because it's going to be up all the time. So anytime it's asleep, fall asleep. And then you'll get 15 to 16 hours yourself. They do experience REM sleep. In fact, they've observed rapid eye movement sleep, or at least rapid eye movements in fetuses in the womb. Rapid eye movement sleep has been associated with the formation of new memories. We think, in fact, it might be associated with the building of the neural networks in the brain. And so you can imagine that newborns need a lot of that because they're building up all their networks. They're starting from scratch. The circadian rhythm will start to develop around 6 weeks old. So for most 6 weeks old, they'll maybe start cutting out one of their wakefulness periods in the middle of the night. And so they might do a full 3 to 4 hours of sleep in a stretch. I've had parents tell me, "Oh no, my baby sleeps through the night." I'm like, "Really? Your 6-week-old is sleeping through the night?" And then I find out that their definition of sleeping through the night is they slept for 4 solid hours. That's pretty normal. 3 to 4 hours by 6 weeks is a pretty normal little cluster. And then they'll delete out another one of their wakefulness periods, and they'll start to sleep, more like 7 maybe hours at a stretch. But that might not happen until babies are like 6 months old. So get used to 3 to 4 hours of sleep a night. Or in one block, I should say. Crying. Newborns do this a lot. They have a repertoire of crying sounds. And I've got for you in the classroom a link to some babies doing different kinds of cries. So like the basic or hunger cry sounds a lot alike. It oftentimes kickstarts, like it's coming. So it's coming. So if you hear that noise coming out of your newborn, it's a good time to start figuring out what might be distressing them. Because once they're into the full hunger cry, sometimes they won't settle down to eat because they have to, they're stuck in it now. The angry cry is a cry that babies will make if something is hurting them. So the angry cry, the pain cry is usually pretty similar. The big similarity between these two is that they have immediate onset. You don't get to hear that sort of wind up of the cry. They just go immediately to crying. Which brings up the issue of colic, right? I mean, some people call their crying baby colic, because anytime the baby's crying and they can't figure out what's wrong with them, they figure, well, they must have colic. But colic is a very specific problem. It tends to emerge when babies are 2 weeks or older. And so that's an interesting thing that a lot of times people will mislabel their newborn as having colic. But colic is defined as crying for 2 or more hours at a stretch without being able to be consoled. So I've got a little video that shows what it looks like, and then also with some ideas of how to cope with it, because it's kind of something that a lot of parents struggle with, or nannies struggle with and things. How about eating? Newborns eat as much as 10 times a day. Because, I mean, if you amortize that little ultradian rhythm that I just showed you, 1.5 to 2 hour cycles, that's like 10 times a day that they're eating. By a month, they've almost halved that. So during that first very acute month, they're pretty much, it seems like, eating all the time. And with a brand newborn, it may take them a while to complete their meal. And so you may be feeding the baby for 45 minutes, and then you might get a 45-minute break, and then you're back to feeding them again, right? So it seems like all they do is eat and poop during this stage, because it seems like all they do is eat and poop, which brings up the issue of breastfeeding. I've got a video attached in the classroom if you want to watch the video on breastfeeding. I thought I'd just hit on what's good for the baby about breastfeeding. One of the number one best things about breastfeeding is that during the first couple of days after birth, mom's breasts are producing colostrum, which is laden with all the antibodies that mom has to anything she has antibodies to, which includes things that she's beaten, illnesses that she had and she recovered from. It also includes anything that she's had vaccinations for. So this gives the baby a really good start for being sort of like vaccinated against things. And in fact, for the rest of the time that the baby breastfeeds, the first part of the feeding is always going to include that antibiotic component. And so babies who are breastfeeding are very unlikely to catch chickenpox, for example, or other things that mom has had or been vaccinated against. So that's a huge advantage. Another huge advantage is it moves the baby's bowels. And so when babies are first born, they have impacted in their bowels all the stuff that they've been swallowing throughout gestation, which includes the hair that they lost at one point during gestation. They swallowed that. All their skin cells and other things that they've shed, all that stuff's all compacted in their intestines. And breastfeeding helps to move that, and so that they can shed that meconium and clear out their bowels. It's really sticky and like tar, and so if you can get that out, it's good. So it's good for and then for the rest of the time that they're breastfeeding, it helps to keep them regular. Babies who are on formula are more likely to have constipation than babies who are breastfeeding. It's also, while speaking of that stuff, it makes the poo not quite as offensive. It smells kind of just like buttermilk, as opposed to formula produces a much stronger smelling feces. Let's see, what else is really good? It's been associated with higher IQs. It seems to be really good for brain development, but it's not, a causal link. It's been associated with those two things. It's been associated with fewer allergies when children grow up. It's been associated with lower rates of obesity when children grow up. So breastfeeding has really good effects over the long term, and absolutely should be encouraged and tried as much as possible. But if a woman can't breastfeed or doesn't want to, she shouldn't be shamed or made to feel bad about that either. Temperament. We can start to see what kind of maybe future personality a baby's going to have based on their temperament when they're newborns. We can measure temperament along a few different dimensions, like irritability, like how much do things bother them? How reactive are they? If a loud noise occurs, does the baby react really strongly, or do they barely notice? And then how active is the baby? How much do they wave around their arms and legs and arch their backs and other kinds of things? You never know what you're going to get when you have a baby. And so, you sort of get what you get. You have your expectations of what a baby should be like, what you think a baby will be like. And parental satisfaction is largely tied to how well the baby fits with the parent's expectations or with the parent's natural personality style. So if there's a good match between how the baby is temperamentally and what the parents expected their baby to be like, parents tend to be more satisfied with their baby. Even if you looking on would think, oh my gosh, I would never want a baby who acts like that, the parents might seem completely satisfied because this is what they thought a baby would be like. So there's a good fit between the baby's behavior and the parents' expectations, or between the parents' own behavior. If the baby is difficult from your perspective, it might be that the parents are like, well, I remember feeling the same way about these same kinds of things, so they feel like it's a fine reaction in their baby. So a goodness of fit between parental expectation and parent temperament, and then their baby's temperament, is the best predictor of whether the parents are satisfied. The other thing that's really important to note is that babies are not just sponges who, react to their parents. The parents oftentimes are reacting to what the babies put out, and they rearrange the environment to make it more possible for their baby to sort of cope, right? So if you expected a baby who sleeps 6 hours a night, instead you have a baby who sleeps in 1.5 hour stretches, you change your reaction, right? You change the environment to accommodate what is clearly something that can't be changed. This is how the baby is. So a lot of times the parental satisfaction is going to be based on how much the parents have to change the environment to accommodate their baby in ways that the parents didn't really want to have to do. So if the parents didn't want to have to make these changes, they may be less satisfied than in parents who had expected to have to make these changes and welcomed making these changes or were willing to make these changes. So parental satisfaction is dependent on a few different kinds of aspects of the baby's predispositions. All right, well, that concludes prenatal development and birth. So I will see you guys in chapter 5.